So this is also very helpful for the patient. You can keep the tongue on the palate, then you can give lateral pressure, and then you can give more force on opening the mouth, on closing the mouth, and acupuncture also they say it is little helpful. So these are the full physical therapy which is available. Um, and arthrosynthesis. So where the patient has ADD without reduction, patient is not able to open the mouth. This arthrosynthesis is also working. So we need to we need to actually take out the inflammatory lavage through the syringe place, and sodium hyaluronate also is working well with this arthrosynthesis. So moving on to case-based. So how we treat case-based. So already we said it's myogenous, arthrogenous and combination of both. Joint pain. So joint pain just called as arthralgia. A patient will be having pain in the preauricular region, just pain, nothing other than that. He will not be having any trouble, deviation, deflection, nothing. There might be a instant trauma, so that would have caused the joint to ache, that's it. So there might be some swelling. So for them we can treat with topical NSC IDS gel and hot and cold fermentation, that's it. So this if you give the patient, it will be very for shorter duration. If any trauma, acute trauma, just joint getting hit because of the cells inflammation, so we give a diagnosis of arthralgia. Joint disorder, that is this displacement with reduction. So this is a very common, we call it as internal derangement. This is very commonly patient will be coming to us. So we should be knowing where to say this diagnosis as ADD with reduction, ADD without reduction. So ADD with reduction, what actually occurs is, like you can see this in the image, the patient will be in a closed mouth position. You can see that the disc is anteriorly and medially displaced. Okay, and as he opening the mouth, the disc will come to its normal positioning. Again, the patient closes his mouth, it will be anteriorly and medially displaced. So this is ADD with reduction. So can you see it is anteriorly and medially displaced on closed mouth position, and as the patient is trying to open, there will be the disc will come to its normal position. Again, it will go back to its position. So this is ADD with reduction. There will be a open. There will be two clicks. Reciprocal click we say. It is on opening one click will be there, closing one click will be there. So this is how you need to come to a diagnosis of ADD with reduction. Is it clear? So the disc on closing, it will be medially and anteriorly displaced. On opening, it will come back to its normal. Again on closing, it will go to its deranged position. So
now how do we visualize this, ma'am?
you cannot visualize it, but clinically that only the reciprocal click. On opening, the patient will be nicely able to open his mouth. There will be no discomfort in opening. He will be able to nicely open. There will not be any restricted mouth opening. Patient will be opening the mouth, but clicking will be there on opening one click, closing one click. So reciprocal click, that is the correct diagnostic this thing for internal derangement, ADD with reduction. Okay, and there will be deviation of the jaw. For example, if the right side is affected, the jaw will be deviating towards the opposite side. Okay, so because this side it is not functioning, so you will not be able to this thing. So that is one of the other diagnostic thing. And patient mainly will be able to open his mouth, clicking will be present, pain will be there in the TMJ region. So these are the main clinical features that we have to know for ADD with reduction. Okay. So tenderness in the preauricular region, reciprocal click will be present on opening the mouth, closing the mouth, deviation of the jaw will be there to the affected side.
Then the MRI?
Yeah, MRI can be taken. MRI only these changes will be seen. So I will show you. So can you see the yellow marks? So you can see that it is black in color, right? So that is the disc. Okay, so that is anteriorly and medially displaced. Actually, the disc has to be there in between the glenoid fossa and then the condyle. But in this patient, the disc is anteriorly and medially displaced. Okay, on opening the mouth, can you see the black thing has gone again up between the condyle and then the mandibular fossa? So that is actually the disc has reduced. So it has become normal. Again on closing, it will attain this anterior and medial displaced. So this will be ADD with reduction. Is it clear? So So you can see this picture. Follow the next picture. So it is like on closing, it is anterior and medially displaced. On opening, it becomes normal. Again on closing, it will go to its anterior and medially displaced because the disc is deranged. But it is, patient can manipulate and he can open his mouth. So management tip will be like, you need to educate the patient, you need to give supportive therapy, and mainly pharmacological therapy, like you can give him diclofenac gel or flurbiprofen gel, hot and cold fomentation, soft diet because already the joint is in problem. Then yawning and all, he has to control it, and bilateral balance chewing. Many patients, if you ask history, they will say one side I'm chewing, so that also should not be there. And a course of antioxidant, actually that is helping because it will be breaking the free radical formation. So if you give a course of antioxidant for a week duration, it is very good. And soft splint therapy. After giving a pharmacological therapy, you can go in for a soft splint therapy. And then identify what etiology is causing that. See if is it an impacted teeth or if any replacement of the teeth is needed, okay, or any malocclusion has to be corrected. So those things we need to see. So like for example, this patient, you can see the video. Can you see which side actually of the TMJ, which side is deviated? Can you see it's the right side it is deviating? So right side the TMJ is affected. So he is not able to, so there is a one click on opening, one click on closing. He is able to open the mouth nicely. Okay, so this is TMD, internal derangement, ADD with reduction. But the joint is deviated to one side, affected side. That is right side is affected. Okay, so your patient will be having TMJ tenderness definitely. That is one important thing to first come to say that whether it is disc related or muscle related. So muscle related, usually TMJ tenderness will not be there. Only disc related TMJ tenderness will be there. So there is preauricular and intraauricular tenderness will be present. And here the patient had once yawning very wide. From that time onwards this started, and from that time onwards he is having clicking. So tenderness was there in the right TMJ region, reciprocal clicking was present, deviation was there towards right side, there is no restricted mouth opening, VAS score was 7. So diagnosis was ADD with reduction. This ADD with reduction we can say only by MRI, but clinical diagnosis, yes, with all these points we can say clinical diagnosis of internal derangement. Then so we gave topical diclofenac and flurbiprofen gel, and then hot and cold fermentation, supportive. So it's this for 10 days. Soft diet and yawning he has to control, and simple joint movements, and a course of antioxidant therapy. So this actually made the patient comfortable. See, then patient was followed up, he was fine. So he didn't have further trouble. So this patient, 30-year-old female patient, pain was there in the left TMJ region. Okay, so she didn't know how it started. Then clinically examining, you can see that tenderness was there in the left TMJ region. Again, reciprocal click was present. There is no restricted mouth opening. Patient was able to open the mouth nicely. Deviation was there towards the left side because affected side the jaw will deviate because that side the jaw will not be functioning. And then VAS score was 7, and there was radiographically you can see there was an impacted 2.8. Sometimes what happens is impacted 2.8 will alter the occlusion. So initially no problem. As they keep, they will change the pattern of chewing. So what happens? There will be a strain in the disc. So initially okay, then as they keep on loading, then the patient will end up in pain in the TMJ region. And this is T scan. T scan is showing that on left side there is more amount of occlusal interference, and patient was then sent for impacted the 2.8 removal. So the patient was given a diagnosis of internal derangement ADD with reduction, and again the same regime was followed. This displacement with reduction with intermittent locking. I told ADD with reduction means opening and closing will not be a trouble, but this intermittent locking is like while opening there will be a little hindrance will be there, then they will open. So there will be a little hindrance in between. So that is ADD with reduction with intermittent locking. So if you know it is ADD with reduction, it is sufficient. This is subcategory. Then you have ADD without reduction with limited mouth opening. Actually, this ADD with disc displacement without reduction, we have two types. Initially, it will be like an acute type and then chronic type. Initially, what happens? The patient will be having restricted mouth opening. then what will happen? It will then over time usage, it will go in for a chronic type where the disc is totally deranged, and they will try to form a false disc the posterior aspect, and the patient then will try to open the mouth normally. Okay, so disc is totally deranged in the anterior and medial direction. Okay, so it's also called as closed lock. The patient on opening, before we saw on opening that is normal, closing that is medial displacement. Here on opening, closing, totally disc is gone. It is only anteriorly placed. So you can see the diagram over here. So can you see the disc is in the closed mouth position, anterior and medially displaced. Again on opening, anterior and medial displaced, totally deranged. So what happens? There will be a pseudo disc formed in the behind part of the disc. So because of which what will happen? Initially patient will be having restricted mouth opening, will go in for a normal mouth opening. But if the patient is not biting on the disc, it is behind the disc, it is formed one pseudo disc, false disc. So patient will be feeling better. So this is the 2-stage. So you can see in the MRI, on open mouth, the disc is totally deranged. Closed mouth also, it is totally deranged. And can you see the black color band, the arrow is point, that is disc. So actually disc has to be there above the condyle, but it is totally deranged on closed mouth. Again on opening also totally deranged. Whereas in ADD with reduction, patient was at least able to bring his disc on the open mouth position. That is the main diagnostic factor. On here in ADD without reduction, on opening the mouth, closing the mouth, totally the disc gets deranged. So you can see here one example, 29-year-old female. She had pain in the right TMJ region. The pain got aggravated on biting a hard food. One fine day she bit on a hard food, then she got pain. Mainly the pain was focused on the right side. So tenderness was there in the right TMJ region. Preauricular, there was clicking present. So I am not mentioning here reciprocal clicking. It is only clicking, only one click. Because patient is having restricted mouth opening. So here you need to note the patient is having restricted mouth opening and deflection is there, and VAS code is 8, and you can see all are impacted. The 8 all are impacted, and we gave a clinical diagnosis of right internal derangement. Only on seeing an MRI you can go and say very definitely it is ADD without reduction. Patient also had pain in the right lateral pterygoid muscle. So we gave a diagnosis of secondary myalgia. Okay. So treatment will be like you need to give muscle relaxants, because since the patient is having pain in the muscle relaxants have to be given, and patient has to be in soft diet, and antioxidant regime has to be given, and soft splint has to be given. So this is one child who is having pain. You can see this is called as deviation. Can you see? Deflection is a S shape. Deviation is he is opening only in one direction. Closing is closing only in one direction. Okay, mainly his right side is affected. So it is deflected. You need to use the word deflected. He's not having any other pain, but he's having pain in the preauricular region. Lateral pterygoid is tender. So again we had to treat the patient with NSAIDs, topical gel, and then soft diet. So all these are very conservative management. We first try to see how conservatively we are able to manage the patient. Then when the patient is repeatedly coming, then we see some other etiological factors are identified, and then only we go for a advance. So this is the nutshell. Normal disc, ADD with reduction, you can see on closed mouth, the anteriorly and medially displaced, the disc is becoming normal. In ADD without reduction, disc is totally deranged on opening and closing the mouth. So management of disc displacement, initially see to it that the pain is addressed. Give them a course of NSAIDs, topical gel, then based upon the severity you can go for a systemic anesthetic, this NSAIDs, and then you can, after that you can give a stabilization splint. if the patient is going to have any night disturbance in sleep and those things, you can give a stabilization spray. So this conservative management will somehow help the patient to at least remove his pain related issues. Myalgia is pain in the muscle region. If it is in one muscle, then you call it as local myalgia. Myofascial pain will be group of muscles, and myofascial pain with the referral will be like trigger points will be present. So this is the difference. So local myalgia, that site alone will be affected. Myofascial pain, the pain will be concentrated in the boundary. Myofascial pain with the referral, trigger point will be there, referral point pain will be there. Is it taking much time? I have to wind it up.
5 more minutes.
5 more minutes. Okay. So you can see here this one patient. So patient is having pain. All these are already discussed. So it's just a nutshell. So this patient had pain, had some family issues, psychologically affected. So there was tenderness in the left masseter muscle, and she had sleep problem during night times. So we treated her with mainly her masseter was tender. So we gave her mainly NSAIDs topical, and then one course of TCA, that is tricyclic antidepressants, mainly with amitriptyline, and then massage therapy was asked to do by the patient, and soft splint was delivered. So these are again a sort of case. And this patient, you can see that the patient when she came only, she had pain in the trapezoidal region, and then when we saw, she had a lot of missing teeth. So immediately we gave her a symptomatic pain relief, and then we told her to first replace all her missing teeth so that the vertical dimension is maintained. This fibrous capsule disorders, we have this subluxation, hypermobility, and then you have this dislocation. So when you say this subluxation, when you say it's dislocation,